All right, so we're going to finish up today the collection of articles on healthcare, that 100 pages or so of articles. We're really close to the end of that. There's a few points I made in the class notes that weren't covered in these articles, and then we'll get into Porter, and Porter's pretty important. He has some good ideas here, and he's actually a whole section of the paper. So here we're going to talk a little bit about this link of insurance to the employer and what the Affordable Care Act has done to that. So you see this first line: company-sponsored insurance is common for working-age Americans, much more in the U.S. than in other countries. It's somewhat a form of paternalism, according to many, but it's diminishing, and that's one of the effects of the Affordable Care Act. More than half of employers were changing insurance in response to the Affordable Care Act. Firms have shifted more costs to employees and given them more control over their health spending. The Affordable Care Act has done that same thing. The schemes, the Affordable Care Act's new exchanges where individuals can shop for policies might eventually provide an alternative to company coverage. I've mentioned earlier there's some that believe that's the ultimate goal of the Affordable Care Act, is to separate healthcare from employment. The share of covered workers with deductibles of $1,000 reached 38% last year. This is a few years old, so I don't know what it is today. More than twice what it was in 2008. Many workers grumble, yet they also get more control over their spending and new reasons to shop around. The Affordable Care Act may be the first step to shift away from company insurance. The firm estimates that if all employees had at least 50 workers drop coverage, they could save around $3.25 trillion over 10 years. So the key here, and this hasn't happened yet, especially large employers, there's been some debates about a few large employers essentially telling their employees, hey, here's some money. We'll give you this money instead of your health insurance. Go out to the exchanges or go out and go find your own insurance, just like you find your own auto insurance, your own life insurance. You can take care of yourself. We'll pay you. You lose the tax benefit of doing that, but then they could change the rules at the federal level to shift from the tax benefit to corporations and make it a tax benefit solely for the employee. So all of that gets back to untying insurance to the employer and then trying to make the patient a consumer so that they pay more of the bill and they act more like a real consumer. Another paper on the Affordable Care Act says the percentage of Americans without health insurance has fallen from 16% to 9%. So here we're talking about uninsured Americans. It expanded Medicaid, which we know that's been a debate state by state. We're seeing the big debate in Kansas right now, a very red state, but is debating allowing this Medicaid expansion. Second, the law established government-run insurance marketplace, or the exchanges. It's not government-run insurance. We already have that with Medicare and Medicaid. The exchanges are using private insurers. These offer subsidies to help those with incomes below 400% of the poverty line, which is a pretty hefty income, $97,000. The third mechanism was the most subtle. Insurance markets always redistribute from the lucky to the unlucky. So here's one that I think should actually make healthy young people upset. There's this as part of the law, as part of the goal here, is to overcharge young people so they can subsidize older people and people who have chronic illnesses. So make the young, healthy people overpay for insurance so that you have money. No other insurance would ever do that without breaking the law. If you took, those that took my property and casualty class, we talked about that with the use of credit scores and other things that, you cannot discriminate one policyholder versus another. You've got to charge them a rate based on their particular group's experience. So before the law, insurers selling new policies to individuals could vary what they charge based on sex, medical history, occupation, other factors. The Affordable Care Act drastically limits this practice. Premiums now vary only with age, smoking habits, family size, and where customers live, but even that discrimination is limited. The old can be charged at most 3 times as much as the young, even if they should be charged much more than that. So yeah, it's essentially this is a transfer of wealth from the young to the old is what it's doing. And studies have shown that the old are much wealthier than the young. So we're essentially transferring from the poor segment of our society in order to subsidize the wealthiest. Now I realize there's a lot of poor, wealthy, elderly people, but in an aggregate, in total, the wealthy older people are getting subsidized by poor younger people. That has made plans cheaper for the riskiest customers at the cost of higher premiums for the younger. So yeah, it's something that should be a concern for you, and it gets back to defining an insurable event. Um, you know, if you overcharge people for insurance, markets are amazingly economically efficient. If you tell the young people they gotta pay twice as much as what their true cost is, somehow magically in the aggregate economics, young people buy less health insurance than they should. The law would work better with more people, healthy people on the exchanges. The ideal way to achieve that would be to nudge Americans away from employer-provided health insurance. More than half of America's under 65 get their insurance through their job. This article says it doesn't really serve any purpose other than the tax benefit. That's definitely the key. The culprit is a long-standing tax exemption for employer-provided health care benefits. This costs taxpayers about $250 billion a year and incentivizes employers to ramp up health coverage rather than raising wages. It would be better to abolish the deduction completely. So they're proposing two of the things on my list. I can live with both of these. So health insurance is tied to employment. Health insurance has huge tax benefits. So he's essentially saying, let's get away from these tax credits. And he's also, I didn't mark this one, but he's also saying, let's untie health insurance from the employer. So usually these two on the problem tend to be tied to these two on the solution. Move from tax credits away from tax deductions. And the reason I say tax credits are directly tied to the individual, not to the corporation. So the deduction happens at the corporation level. You go to tax credits for individuals. Then you move away from it being tied to the employer and you move it to being tied to the employee. All right, so let's look at class notes. That's the end of all of those. Wow, all of those articles. That's a lot of them, 140 pages of article, and I didn't cover all of them. Some of them were pretty minor issues. I just put in there. You know, I would still read the highlights because I think they're interesting points, but they may not fit into the paper too well. But one of the biggest issues we have to address here is this issue of over-treatment and over-diagnosis. So just a few points from the class notes on page 43. For the first time in history, once we started really beefing up health insurance, especially in the 70s, people started going to the doctors even when they were not sick. So regular checkups, regular screenings. So we're going to the system that wants to treat us, and we're going to them and saying, hey, see if you can find something wrong with me so you can operate on me. Can you imagine if we did that with our cars? There's absolutely nothing wrong with your car, but you go to a mechanic and say, hey, can you find something wrong with my car? And I'll pay you to fix it, whatever it is. I want my car to run well. And I'd rather catch it early than later. Boy, we would be spending a fortune, especially if we had subsidized insurance to pay for all of that. So how do you balance early detection with over-treatment? This was my argument. I remember President Obama said we should provide, insurance to cover 100% of checkups because you want to catch stuff early. And I was thinking all this data here that, boy, the healthcare system, first of all, with young people, they don't find anything anyway. And if they do, it's usually too late because it's something really serious. But with older people, they'll always find something. And most of the things they'll find, or a lot of things they find, would have never done any harm. So how do you balance that bad incentives in the healthcare system with the fact that you want to catch stuff early? And that's very, very true. And there are definitely some cancers like colon cancer that if you catch them early, they're slow moving. You catch them early, you can save lives. Very, very effective. But there's others like prostate cancer, like breast cancer, like thyroid cancer. A lot of people that they're screening and treating are actually going to be worse off because of that. So how do you balance those two? Screening has become more accurate in quotes mainly because it's much more detailed, much more specific, but more early diagnosis is not reducing death rates. So often the treatment for early diagnosis is more dangerous than the ailment itself. So if someone may have mild hypertension, so they take the medication, and this medication caused them to faint and have an auto accident. I know a gentleman, actually the guy whose place I took at head of equities, he was head of equities at UTSA, retired before I took his job. There was like a couple of people in between. I remember he ran his car off the road and wrecked, and I think it was exactly this. He was on this medication for hypertension, caused him to faint while he was driving, and he almost, he wasn't injured. His car was damaged, but he wasn't injured. But yeah, there's the treatments themselves can cause serious problems. Almost everyone has an abnormality of some kind. If we screen hard enough, when subjected to a detailed screening, 86% have at least one abnormality. The average person has 2.8. If people with no symptoms go for screening, 10% they're going to find gallstone problems, 40% they'll find knee problems, and 50% they'll find something wrong with your back. Now, there's no way I would ever let anyone touch my back or my knees if I wasn't in pain. They may tell me it's going to get worse, or I'd say I'll wait until I feel the pain. Of 2,000 women given mammography screening, one death will be prevented. So that's good. One person out of 2,000. Two people will have major surgery where they didn't need it. The surgery, they could have gone completely without the surgery and they would have lived just as long if they would have with the surgery. 5 in 15 would have died anyway. That's part of the nature of cancers. Just because you find it doesn't mean you treat it, doesn't mean you're going to save the person. There are a lot of very aggressive cancers. 250 to 500 will be given a false alarm. So they'll be given a bad screening, so then they're stressed out, what do I do? And then they go back and they check again. They say, no, you're okay, no problem here, but they've been incredibly stressed out. So that's 1 in 4. 1 in 8 to 1 in 4 women will be given a false positive. That doesn't mean there's surgery, but it does mean they're given a tremendous amount of stress. Some drugs, take this last drug, Lipitor, helps 1 out of 100 people taking the medication. It's $1,500 a year, and we give it to 100 people because there's one person that will be helped by that medication. We're starting to do much more precise thresholds, much lower thresholds. So we're throwing people into these categories, what we call pre-categories, pre-hypertension, pre-diabetes. So they don't have the disease yet, but they have numbers that show they're moving toward a disease. So we're going to treat them with this pre-disease. They've been changing these thresholds for cholesterol, hypertension, the prostate cancer, obesity. They keep getting reduced. I can tell you on obesity, the numbers keep getting lower and lower. It's amazing. I think they're so exaggerated. You have to think about the Center for Disease Control. They have an incentive to say Americans are obese because they get more federal funding. So there's bad incentives. I remember watching a video. It's a really bizarre video. Someone's presenting to a group of high school students about the problem of obesity in the United States, and they had these students all scared to death. There wasn't a student in there with more than 10% body fat. They were as thin as they could be, but they're all started working, talking about giving people eating disorders or those kind of things, and just talking about this to a room full of people that were obviously did not have weight issues, but these numbers, and you start lowering the threshold lower and lower and lower, you start scaring people that everyone's going to have these diseases, everyone's going to be obese. I even saw an article that said 100% of Americans will be obese by 2050. I mean, just ridiculous types of statistics, and that might be true just because they reduce the definition of obesity so low that you'd have to be dead not to be obese. So these preconditions, they're not providing any, and this is the key, they're not providing any noticeable reduction in the disease later. Often it's just better to monitor than to treat, but we treat them because they have pre-hypertension, and then they have, they faint while they're doing work and they harm themselves even more. Experts are pushing for lower thresholds, but the ones pushing for these lower thresholds often have a financial incentive to do so. So our goal is not to find more cancers. That's when we'll get to Michael Porter and outcome-based medicine. The goal is not to find more stuff. the goal is to improve our health, and to save lives. So overtreatment, overdiagnosis is a huge one. And then let's get to this American lifestyles. Why do we focus so much on treatment? And a lot of that's because the healthcare system gets paid for treating people. It does not get paid for making us healthy. So us going to the gym doesn't make any money for the healthcare system. So American lifestyles, our eating problems, our exercise problem, they need a change. But we prefer medical treatment. It's a lot easier. There's one movie, I don't recommend this movie. There's another movie we're going to watch that I found much better. It's called Escape Fire. It was okay, but in that movie they said we don't have a health care system in America. We have a disease management system. We don't make people with diabetes and heart problems, we don't make them healthier. We just treat the disease. So it's a chronic thing versus having them get out and exercise and change what they eat. So which makes more sense for an overweight 55-year-old man? Should he be, if he's overweight, he's got heart disease and diabetes, should he change his diet and exercise? Or should we give him drugs and stents and treatment? And after reading about stents, I can tell you, I'm going to ask my doctor if they ever say I need stents. It's like, are you sure? Can we monitor? That thing really scares me just looking at exactly what that treatment is. What does insurance pay for? Well, insurance pays for the drugs, the stents, and the treatment. It doesn't pay for diet and exercise, which is more profitable to the healthcare system. So, you don't have to have a medical degree. That if an overweight 50, 60-year-old person walks in who tells you they're smoking, they never exercise, they're eating an incredibly high saturated fat diet, my guess is you would be able to tell them what they need to do, and you would not have to think too hard about it. It'd be pretty straightforward. One example they give in one of the articles I read is that there's 9,000 billing codes in medicine, but there's nothing out there for a cure. There's no billing code for curing people. So it's things they're doing to us, not how they're improving us. Diabetes could be cut in half by 5 to 10% reduction in weight and by walking 30 minutes a day. So we're not saying you got to train for the Olympics. Especially people in their 50s and 60s, it doesn't take much. We're so stationary in our lives that just reducing our weights 5 to 10%, take someone who's 300 pounds, that's losing 30 pounds. It's not massive. And walking 30 minutes a day, which those two would go together, walking 30 minutes a day. Where I ride my bike, the hills are steep, the people there walk, and boy, they all look so healthy, and they're not walking hours a day. They're walking, 30 minutes to an hour a day, maybe. But very, very healthy people. You can just tell looking at them. It's a very healthy neighborhood. So, which should our system encourage? The exercise and better eating, or the treatment? So again, over treatment, over diagnosis, and then just to give you a little bit on the baby boomers. 70% of healthcare costs are concentrated on these diseases, most of which are focused on the elderly. Asthma is the only one that's not, but all the others are on the elderly. Depression might not be as much, but definitely affects all ages. Of Americans over 60, 76% take at least 2 drugs. I'm on 2 drugs now. I'm only 57. 37% take at least 5 drugs. Of Americans over 65, more than 50% have 5 or more chronic conditions. 1/3 of people who die have major surgery in their last year of life. 15% of terminally ill men have unnecessary and painful prostate screening. I mean, it's just crazy that you'd have people at that age. I mean, someone who's terminally ill, right? They're going to die of something else, and we're screening them for prostate cancer. It just doesn't make sense. How much do we spend to extend a life 1 month if that life is comatose, sitting in the hospital, and it's going to cost $1 million? You'll get into that when you watch this one video I want you to watch. So are we prolonging life, or are we just prolonging dying? These are obviously very, very sensitive issues. Politicians bring up the death penalties and, pushing grandmother off the side of a cliff in a wheelchair. Those are the commercials that were happening. So there's definitely some huge issues here that I'm not saying they're easy. You're allowed to take any approach you want, realizing that politically they could be completely untenable, but you can still push them. So end-of-life care, baby boomers, that's a big part of this problem. Quality city to city and cost city to city. Just a few other quotes I want to give you, and then I want to show you a website. I won't take you to the website, but I invite you to go to it. I'm not sure it's in San Antonio yet, but you might look. So deaths for heart surgery, different hospitals, they range from 1% to 18%. Reporting the data to the public caused immediate improvement, 41% reduction in deaths. So hospitals are fighting having their quality data being released to the public, and yet when that data is released to the public, hospitals get better. They improve their rates, because it definitely does influence how consumers shop. I think the data should be released. I understand the arguments doctors and hospitals make. Some hospitals attract more difficult cases, but they can make that argument. They can advertise, and they can make the argument that they have a different clientele, and this data can be adjusted for that in some way. You know, the age of the people coming, or what state they were in when they arrived. So there's ways to adjust for these, but still, hospitals fight for this. So what's happening? This thing right here, Vitals Smart Shopper. It's a really tough one because there's so many S's, but Vitals, VITALS, smartshopper.com. You might try that out if you ever need some screening or tests, especially more expensive tests. You might say, I don't care because the insurance company is paying for it. But what this company does is they say, hey, you know what? There's 4 places you can go in San Antonio for this screening, but there's one that's cheaper than all the others. You don't care because your insurance is paying for it. However, if you go to the cheapest one, it's about 3 miles further away for you than one of the others. But if you go, we'll pay you $50. So, you know, you got your deductible of $35, and so you're going to pay $35 no matter which one you go to of the 4. However, if you go to company D, which is a little bit further away from you, we'll pay you $50. So essentially, we'll reimburse you your deductible plus an extra $15. So you might look at that as an interesting approach. It's still out there. I clicked on it when I set all this up, and it still works. It still is a website. I just don't know if it's in San Antonio yet. Yeah, but inconsistency between cities. Doctors and hospitals, when they compete on outcomes, it certainly makes a difference. What outcomes would you want them to compete on? With a few examples. Bounce back rates, we'll talk about this a little bit when we get into Porter. But bounce back rates, how many have to come back within 90 days? Average length of stay per treatment. You know, would you want to go to a hospital where the average stay is 3 days or the average stay is 2 days? Complication rate, risk-adjusted mortality rates. So that's where I'll talk about risk-adjusted. So you look at the mortality rates, but you risk-adjust based on the age and condition of the patient. So doctors aren't hurt just because they have a better reputation, so they get much more difficult cases. The never event rates. Sponges left in a patient. They operate on the wrong patient or on the wrong side of the patient. If you've been in a hospital or even in just a lab lately, you'll notice they keep double checking your name and birth date every time they start poking you, just to make sure they have the right person. So it seems like that particular one has really been a focus. Death following an elective surgery, what happened there? Infection rates. Remember, healthcare is the 3rd leading cause of death in the United States. And by healthcare, I mean healthcare mistakes are the 3rd leading cause of death in the United States. It's just absolutely insane. The hundreds of thousands of people that are dying because doctors didn't wash their hands. Safety culture survey scores. There actually is a high correlation between these surveys and their hospital staffs and what their actual scores are. You would think hospital staff might lie and say their hospital's better. But one of the questions I asked them, would you have surgery in your own hospital? One question I really like, if you ask nurses to grade their own hospitals, that by itself would probably be enough for you to pick which hospital you want to go to, because nurses are incredibly knowledgeable of what's going on, and they also tend to be very honest in their opinions. And so if a nurse says, I would never have surgery at my hospital, you probably don't want to have surgery at that hospital. Volumes of treatment. We'll talk about this with Porter. There are certain treatments that you want to be with a doctor that's done hundreds of thousands of these. You don't want a doctor who's on his fourth try, fifth try. So some treatments, volume is extremely important to outcomes. Percentage that use less invasive techniques. I mean, it's pretty remarkable. There are some hospitals that still use older techniques that are far more dangerous. They cost a lot more, so that may be their way why they do them. They're far more dangerous when there are less invasive techniques. It's amazing what they do now. I mean, some of these studies you've probably seen, how they take the appendix out now. I mean, it leaves very little of a scar, and it's just far less risky for infection and complications. Use of electronic records is extremely important. Open notes, video recording. I've noticed that with a few doctors, they'll actually record their meetings and make a lot more notes, and then that will be converted into written. You know, a lot of my life going to doctors, they didn't write anything down, and I think they just did their files at the end of the day and probably forgot half of what went on. But some of the doctors I've been to, they have a recording device, and they're constantly putting something in the recording device, and someone's transferring that. So electronic records, open notes, video recording, those kind of things that have shown to make outcomes far higher quality. So information on quality, it's one of my possible solutions. Let's release this information and let the consumer decide where they spend their dollars. And the nice thing is, there's not really a correlation between quality and cost. The highest cost hospitals are not necessarily the highest quality. The lowest cost hospitals are not necessarily the lowest quality hospitals. So consumers could actually find a higher quality hospital and save money at the same time. So outcome-based, so we're definitely going to talk a lot about this with Michael Porter. But we want, to see what is the benefit here of focusing on the outcomes. So consumers pay for better health but not treatment. How does treatment work for us? So this is the negative side. So Porter will give us the positive side of outcomes-based medicine. Here's the negative side of a treatment focus. A Rand Corporation study found that people enjoying free healthcare, which means insurance from their employer, spend about 50% more than those who pay most of their out-of-the-pocket. People with free care also have 25% more likely to see a doctor, 33% more likely to go to the hospital, and yet, you see that last point, they're not any healthier than the group that spent less. So we're spending 50% more, seeing doctors 25% more, going to hospitals a third more, and yet there's no difference in outcomes. Reimbursement for good outcomes, not for volume of treatments. Use of video records. One survey showed that before video, and this last one's pretty incredible to me. This has to do with, getting doctors to reduce errors, hospital checklists. So one survey showed that before they used videos, only 6.5% of surgeons washed their hands before surgery. After they knew the video was there and recording them, the amazing thing is it didn't rise to 100%, it only rose to 90%. But you have to think about that. You're going into surgery, and there's surgeons who are not washing their hands. You think about that with COVID going on and everything else. It's just pretty remarkable. So let's talk about Michael Porter. That one really set us up, Michael Porter, outcome-based medicine. So you might want to pause the video and go find the Michael Porter article. I'm going to cover it fairly quickly. We might finish it in this lesson, we'll see. But so if you hit pause, go find the article. All right, so what does Michael Porter have to say? You've heard of Michael Porter. He's the one that invented the Porter's 5 forces. He's the value chain management guy. So all these things we use in finance. He's still around. This is a pretty recent venue for him getting into healthcare reform. So he's out there. He's a famous professor. I actually have a book that he wrote with his autograph. That's not the reason I like him. I think he's got some important stuff to say. Some of his theories get a little tedious. He really gets down into the details. So what I think you're going to find here, you may have to quote him, but as you read this article, what always hits me is, what does this really mean? What is he really saying here? So let's walk through this. So he starts off by just saying what the U.S. has experienced is true around the entire world. Every healthcare system is struggling with rising costs, uneven quality, despite all the hard-working, well-intentioned professionals. So it's time for a fundamentally new strategy. So what is he proposing? So all of this falls under the solutions. He may address some of the problems in here, but we're getting to the solution. So at its core is maximizing, and this is the key right here, maximizing value for patients. We're not maximizing earnings for hospitals. We're not minimizing costs for employees. We're maximizing value. Be careful with the word value. Value includes both the outcome of the healthcare, but also includes the cost. So it achieves the best outcomes at the lowest cost. I mean, these two balance. It may not be the actual lowest cost. It may not be the best outcomes. When you combine these two, maybe you get the second best outcome, but instead of costing $1 million, it costs $15,000. So it's not quite the absolute best. You're not doing everything possible in the world and spending billions of dollars on someone, but it's outcomes versus costs. So always keep that in mind. When he uses the word value, he includes costs in that definition. So we must move away from a supply-driven healthcare system. We've already talked about that, the incentive to treat, organized around what physicians do, and that's pretty important, and toward what a patient-centered system organized around what patients need. So again, we're shifting the focus. Everything that's, and the key here, that all sounds, oh, that's kind of nice, warm, fuzzy words, but the key for him is when we focus to what the patient needs, that means all the measurement system needs to change. We need to be measuring what patients need and not measuring what hospitals are doing. So a lot of this is data driven. How do we get the data to figure out if patients are getting what they need? We must shift the focus from the volume and profitability of services provided, which includes physician visits, hospitalizations, procedures, and tests, to the patient outcomes achieved. We must replace today's fragmented system in which every local provider offers a full range of services with a system in which services for particular medical conditions are concentrated, and this is a key to his solution, health delivery organizations and right locations to deliver high-value care. So one of his solutions is there may only need to be 3 or 4 of these hospitals in the country or in the state. People may need to travel 5-6 hours or even fly, and that travel cost will be worth it because these health delivery organizations are going to be so specialized that the travel costs will more than be made up with the volume discount, the economies of scale, the high quality because they have so much more experience. It requires restructuring how healthcare delivery is organized. That's key. How it's measured and how it's reimbursed. That's a tall order. When you say it's how it's organized, right there we're talking about there are existing forces that are going to resist change. That's going to make it difficult. How it's measured. People are so used to being measured the way they've always been measured. Changing measurements is really tough. People understand the existing system. They're really worried with a new system. How will I be paid? Will I be paid fairly? That's not that they think the current system's fair. It's that they know the current system and they know how to manipulate it. So if you start messing with that current system and it's going to start messing with their pay and their workflow and everything else, they get really nervous. And then obviously the measurement is tied to the reimbursement, and so obviously they're going to be very concerned about that. So how do we figure out what we're trying to achieve here? So narrow goals such as improving access to care, containing costs, and boosting profits have been a distraction. So he says those are the wrong ones. Providing access, that's the Affordable Care Act. Let's give more people access. Well, that doesn't, you don't give people access to a broken system. So, you want to fix the system maybe before you give access, or at least fix the system while you're giving more access. Containing costs, well, as we know, containing costs does nothing more in the system other than shifting the cost around. The system still gets its money. It just shifts around how they do it because the billing system is so opaque. Boosting profits have been distraction. Access to poor care is not the objective, nor is reducing costs at the expense of quality. Increasing profits is today misaligned with the interests of patients because profits depend on the increasing volume, not delivering results. Now, he's not saying profits are bad. What he's saying is the incentives for profits, the pay, the firms that make the most money are the ones who deliver the best outcomes for patients. It shouldn't be based on anything else other than that. So he still wants the incentives of profits. He just wants them shifted from volume and away from volume towards outcomes. In healthcare, the overarching goal for providers as well as every other stakeholder must be improving value for patients. For value is defined, again, as health outcomes achieved that matter to patients relative to the costs. Again, don't forget that relative to the cost of achieving those outcomes. Moving away from fee-for-service and toward performance-based reimbursement. So there's the reimbursement. I think that sounds wonderful, and you're not going to get his full answer here. This may be something you want to do a little more research on. I'm still trying to get us a speaker maybe for this class who's an expert on outcome-based medicine and see if he'll talk to us about what he's done. My only issue is our class is just so late in the evening, but I still would like to do that. I'll keep you posted, obviously, a few weeks before. But how do you actually do that? How do you come up with a measurement system where you pay for the right things and the people getting paid don't manipulate that in a way that they get more money even when they're not achieving the goals you want? Measurement and reimbursement are so critical to his solution, and boy, this is such a complex system. I really question, can you really achieve this? These pressures are leading more independent hospitals to join healthcare systems and more physicians to move out of private practice and become salaried employees at hospitals. This is the other thing he's talking about is the system is too disjointed. There's too many silos, too many small kind of community hospitals. We need to combine everything together in these massive conglomerates where they treat the entire patient. That we don't piecemeal them here and there and all over the place. It's a holistic system. Here's a picture of his solution. I would recommend you put this picture into your paper, but you'll have to explain it some. So he starts off with integrated practice units. We'll talk about IPUs, somewhat what we're talking about of units first integrated, so they talk to each other, so a patient is not, you go here for this, go here for this, go here for this, but it's a holistic approach, and you organize it in a way that the volumes go where the volumes are best treated. Measures outcomes and costs for every patient. I actually think that's the hardest part of all. Move to bundle payments for care cycles. So essentially what they're saying is, we're going to pay you, your organization, for how healthy your population is. If you make them healthier, there's less diabetes, there's less heart disease, more people are exercising, the air is cleaner, the water is cleaner, there's fewer hospital mistakes, fewer hospital stays. You look at, how many sick leave days are there. We pay you for that. We don't pay you for doing surgeries. We don't pay you for these other things. We pay you for how healthy the populace is. That sounds wonderful, but boy, does that sound like a complex thing to set up. Then they have integrated care delivery across separate facilities. So that's, again, very similar to number one. But even as you change from one building to the other, they don't drop you and suddenly treat you for something else, but they know your whole history. Expand excellence services across geography. So all of this, I'm just going to keep harping back on, all of this is so incredibly tied to data. And that's why he has number 6 here at the bottom. Don't forget number 6. Don't copy this in and forget number 6. An enabled information technology platform. Now, I know hospitals that are starting to do stuff like this. There's several doctors in my graduate program that I teach in. So in this graduate program, it's the executive MBA. There's several doctors who I've heard them talk about the kind of things that are these outcome-based, and they talk about major flaws in the way that things are being asked and recorded. And I can see their point. They know patients and they know their medicine much better than anybody else. So it's tough. It's not that they don't understand what's trying. I think they really understand the goal and what's trying to be achieved. I think they just know the nuances that really make it really hard to measure these things. So he talks about the problem. We already talked about raising costs. The approach, improve outcomes, and what's the model. So here's a good quote from this paper. The strategic agenda for moving to a high-value healthcare system comprises 6 independent components, and so we saw those 6 components. Actually, that sentence would work well, that first part, and then show the chart rather than reading the rest of that, but that's his model. So switching over to page 5, no organization, however, has yet put in place the full value agenda across its entire practice. He'll mention a few organizations, and you'll see in the video we want to watch a couple of those organizations that have had some really pretty successful numbers, that they're very high quality and their costs are low, so they're cheaper than most others, and their quality is much higher. Now, we looked at one of those, I think it was Cleveland, as we mentioned, and we saw them in an earlier article where their costs were like 50 times higher than the guy in India. So even our lower cost, higher quality are still extremely high cost versus what other people are doing. So let's talk about this IPU. What is an IPU? At the core of the value transformation is changing the way clinicians are organized. The first principle is structuring any organization or business to organize around the customer and the need. In healthcare, that requires a shift from today's siloed organization by specialty and discrete service to organizing around the patient's medical condition. We call such structure the IPU. Team made up of both clinical and non-clinical personnel provides a full care. So, dietitians, exercise experts, it's the entire person. IPUs not only provide treatment, but also assume responsibility for engaging patients and their families in care, such as education, counseling, adherence to treatment, prevention protocols, supporting needed behavioral changes, stop smoking, weight loss. And IPUs personnel work together regularly as a team toward a common goal, maximizing the patient's overall outcomes as efficiently as possible. Sounds great, doesn't it? Contrast that with the approach taken by the IPU at Virginia Mason Medical Center. So here's one. You might Google them and see if you can find something out. So this is the example he's showing of a firm that's doing that. The impact on value has been striking compared with regional averages. Virginia Mason's clinic missed fewer days of work, 4.3 versus 9, and need fewer physical therapy visits, 4.8 versus 8.8, dropped it in half. In addition, the use of MRI scans to evaluate low back pain has decreased 23%. Better care has actually cost less. Virginia Mason has also increased revenue through increased productivity rather than depending on more fee-for-service visits to drive revenue from unneeded or duplicate tests and care. So essentially, their revenue is higher not because they're charging more, but they found a way to do the same activities without it costing them more. So they increase their productivity. Instead of doing 5 of these a day, they do 8 of them a day, and they do it in the same amount of time with the same amount of resources. So if you can do 8 a day, you get 50-60% more revenue, and your costs haven't gone up because you're doing it with the exact same amount of resources. Whenever IPUs, let's see, the clinic sees about 2,300 new patients per year compared with 1,400, so you can see they've really increased their productivity, and it does so in the same space with the same number of staff and members. I mean, that's any business model you look at, that would be great. Whenever IPUs exist, we find similar results: faster treatment, better outcomes, lower costs, and usually improving market share in the condition. So here's a picture of an IPU. I'm not saying you have to read all this, but that may give you some idea of exactly what he's looking at. Organized around the medical condition, care is delivered by multidisciplinary teams. Providers see themselves as part of the organization unit. The team takes responsibility for the full cycle. They don't drop the patient just because they've left surgery. Patient education is part of it. Unit has a single administrative and scheduling structure, so you see there's a lot of economies of scale here. To a large extent, care is co-located. So you cross across different entities. The physician team, captain or clinical care manager, oversees each patient. So you have kind of a goalkeeper there that keeps track of everything. Team measures outcomes, costs, and process for every patient. The providers on the team meet formally and informally on a regular basis. So providers that are providing different services talk to each other. You'll actually see that in that video. One hospital was actually doing that, a room full of 10 people. The question that raises in your mind is, why we got 10 people sitting in this room talking about one patient? Isn't that more expensive? But he's saying no, it's actually less expensive because you don't end up giving care you don't need. And they don't talk hours about the patients. They talk about the patient for 20, 30 minutes, and they all agree on the approach. Joint accountability is accepted for outcomes and costs. So that's his idea of IPU. Measuring outcomes and costs for every patient. Rapid improvement in field requires measuring results. So in any field, requires measuring results. A familiar principle in management. Teams improve and excel by tracking progress over time and comparing their performance to that of peers. Rigorous measurement of value, outcomes, and costs is perhaps the single most important step to improving healthcare. The only true measures of quality are the outcomes that matter. When those outcomes are collected and reported publicly, providers face tremendous pressure and incentives to improve and adopt best practices, and that kind of feeds on itself. The outcomes that matter to patients, what are they? Tier 1 involves health status achieved, patients care about mortality rates, obviously, but there's also concerns about functional status. Can you still walk? Can you still eat by yourself? In the case of prostate cancer, 5-year survival rates are typically 90% or higher, so patients are more interested in things, incontinence, sexual function. So there's other things patients are worried about that doctors and hospitals need to measure. In prostate cancer, it's that incontinence and impotence. Well, these things happen, versus saying, hey, you know what? There are some hospitals that have fewer of those than others. What are they doing differently? How can we improve? So that's tier 1. Tier 2 relate to the nature of the care cycle and recovery. High readmission rates, frequent emergency department bounce back rates may not actually worsen long-term survival, but they are expensive and frustrating for both the providers and the patients. None of us wants to have to go back to the hospital for some mistake that was made. The level of discomfort during care and how long it takes to return to normal activities. Significant delays before seeing a specialist for a potentially ominous complaint can cause unnecessary anxiety. Delays in commencing treatment prolong return to normal life. Even when functional outcomes are equivalent, patients whose care process is timely and free of chaos, confusion, and unnecessary setbacks experience much better care. So there's other things to measure that right now doctors don't measure at all, hospitals don't measure at all, because they don't really care. It doesn't change how much money they make. And in some cases, they may actually make more money by making things worse for the patient. Tier 3 outcomes relate to sustainability of health. So the first one was, are you going to live, and will you have any major complications? The second one is, how frustrating is the process? The third one is, how sustainable is the process? Hip replacement, how long does it last? It lasts 2 years in the worst case, and 15 years in the best case. If tier 1 functional outcomes improve, costs go down. If tier 2 and tier 3 outcomes improve, costs go down. So we can do better, and it costs us less. By failing to consistently measure the outcomes that matter, we lose perhaps our most powerful cost reducer. So measuring the cost of care, really, really important to what he's talking about. For a field in which high cost is an overarching problem, the absence of accurate cost information in healthcare is nothing short of astounding. I think it's because it's so complicated. It may be the bad incentives as well, I'm sure, but it is very, very complicated. If any of y'all dealt with activity-based costing, collecting costs at a functional level is extremely difficult. Few clinicians have any knowledge of what each component of care costs, much less how costs relate to the outcomes achieved. We've been able to hide our prices for years inside insurance products, but that's going to end as more and more people move to new high-deductible products. So there's that consumerism side that might help drive this as well. Where consumers are spending more, they start asking questions about cost and quality. We're going to have to be able to communicate exactly what we are giving patients, employers, and insurers for their money. Most hospital cost accounting systems are department-based, not patient-based, so that's a key one right there. That's true for most of corporate America. There's a few corporations that are trying to get customer-based costing, so they know exactly how much each customer costs, so it's almost like return on equity on each customer. But it's pretty tough. It's hard to get data at that level. So you want cost accounting to be on a patient base and not department base. and designed for billing of transactions reimbursed under fee-for-service contracts. So the current system is not set up to focus on the patient. To determine value, providers must measure costs at the medical condition level, tracking the expenses involved in treating the condition over the full cycle of care. This requires understanding the resources used in a patient's care, including personnel, equipment, and facilities, the capacity costs of supplying each resource, and the support costs associated with care, such as IT and administration. Then the cost of caring for a condition can be compared with the outcomes achieved. Time-driven activity-based costing, which again is a really tough thing to get right. Providers are achieving savings of 25%. Now what he's saying is some of them have moved to this, maybe they haven't gotten it perfect, but they're already seeing, like Virginia Mason, already seeing huge advantages, huge improvements. Providers are achieving savings of 25% or more by tapping opportunities such as better capacity utilization. There's that economies of scale, more standardized processes, again economies of scale, better matching of personnel skills to task, locating care in the most cost-effective type of facility, and many others. A lot of these are economies of scale. Let's find the best place to do this where there's high volume. We can spread our fixed costs out better, have better practices and procedures because we do it so much, we get better at it. So Virginia Mason again found its costs. It costs $4 per minute for an orthopedic surgeon or other procedural specialist to perform a service, $2 for a general internist, and $1 for less for a nurse practitioner. And a lot of those cost differences, focusing the time of the most expensive staff members on work that utilizes their full skill set, is hugely important. So there are things nurses should be doing. You shouldn't have specialists doing. Clinicians and administrators battle over arbitrary cuts rather than working together to improve the value of the care. You got to get the whole person on a team. All right, the third one, bundled payments to care cycles. I'll go faster over these last few ones. Neither the dominant payment models in healthcare, capitation, fee-for-service. Capitation is that HMO, that kind of health maintenance organization kind of way. Directly rewards improving value of care. Global capitation, a single payment to cover all a patient's needs, rewards providers for spending less, but not specifically improving outcomes. So capitation encourages hospitals to spend less and do less, so the patient might be worse off. Fee-for-service encourages hospitals to do more, but may do unnecessary things which might make it worse. So fee-for-service couples payments to something providers can control, but not that the overall outcomes. Providers are rewarded for increasing volume. So you have two systems that are going that neither one of them are focused on the quality of the outcomes. The payment approach best aligned with value is a bundled payment that covers the full cycle for acute medical conditions, the overall care for chronic conditions for a defined period, usually a year, or primary preventive care for a defined patient population. A payment is tied to overall care for a patient with a particular medical condition, aligning payment with what the team can control. Providers benefit from improving efficiency while maintaining or improving outcomes. Oh, that sounds so wonderful, but again, think about how possible that really is. Sound bundled payment models should include severity adjustments or eligibility only for qualifying patients, care guarantees that hold the provider responsible for avoiding complications, such as infections after surgery, stop-loss provisions that mitigate the risk of unusually high cost events, and mandatory outcomes reporting. So here's one. Walmart introduced a program which it encourages employees who need cardiac, spine, or elective surgery to obtain care at one of the just 6 providers nationally. So you can see they're asking people to travel. There's a list of them, the Cleveland Clinic that I mentioned earlier, and a few others. The hospitals are reimbursed for the care with a single bundled payment that includes all physician and hospital costs associated with both inpatient and outpatient pre- and post-operative care. Now that sounds a lot like capitative care, but so you have to see what the incentives are on the other sides other than just getting the inpatient out. So there needs to be measurement on how well the inpatient does to get it beyond just regular capitation healthcare and actually do his model. Employees bear no out-of-pocket costs for their care. Travel, lodging, and meals for the patient and the caregiver are provided. That's pretty amazing. The travel is covered as long as the surgery is performed at one of those centers. Now, why would Walmart do that? Because they know those 6 centers have the best prices and the best outcomes. And so it saves them money and the patient ends up healthier at the end. Integrated care units, I think there's a little overlap here, but we'll still go through it. There's a huge opportunities for improving value as providers integrate systems to eliminate the fragmentation and duplication of care and to optimize the type of care delivered in each location. To achieve true system integration, organizations must grapple with 4 related sets of choices: defining the scope of services, concentrating volume in fewer locations, choosing the right location for each service, and then integrating care for patients across locations. I think there's a high overlap between this and the IPUs. A recent study of the relationship between hospital volume and operative mortality for high-risk types of cancer surgery found that as hospital volumes rose, the chances of patients dying as a result of surgery fell by as much as 67%. So it makes a big difference. You're often better off traveling longer distance to obtain care at those locations. Less complex conditions and routine services should be moved out of teaching hospitals into low-cost facilities with charges set accordingly. So these high-octane, Mayo Clinic, Cleveland Clinic, they shouldn't be doing these more routine things. We should move those things out of those hospitals, have them focus on where their high skills are really needed. Matching the complexity and skills needed with the resource intensity of the location, which will only optimize cost but also increase staff utilization and productivity. Expand geographic reach. Again, we kind of just covered that in number 4. Superior providers, particular medical conditions, need to serve far more patients and extend their reach through strategic expansion of excellent IPUs. Number 6, the technology platform. Often IT systems complicate rather than support what he's talking about. Value-enhancing IT platform has 6 elements. It is centered on the patients. It uses common data definitions. It encompasses all types of patient data. The medical record is accessible to all parties involved in care. Obviously, there's issues there with privacy and those type of things. The system includes templates and expert systems for each medical condition. So again, trying to just take best practices and let's make sure everybody's using those. And then the system architecture makes it easy to extract information. That sounds like a multi-trillion-dollar project, given that there's so many hospital systems out there that are not well organized or integrated. And so the final conclusion, wow, this is good, right on time. Providers that cling to today's broken system will become dinosaurs. Reputations that are based on perception, not actual outcomes, will fade. All right, so where are we on this? We've covered all the articles. We've hit, I think, everything on the rubric. We can look back at the rubric and see if we've hit everything. I'll do that before our next session. So what else do we want to cover? So we have the video I want you to watch. There's a little bit I want to cover on the text, just a little bit, I think. I don't think I've covered that yet. I'll have to look back in the videos. It's been a while since we've been doing this over several weeks, and I myself have done this over a couple weeks. And then the last thing might be an outside speaker. I might save the outside speaker. I'm trying to think through this to give you a chance. I've started your paper. I've gotten pretty far into it before we have the outside speaker. That way you can test some of your ideas. We'll see. I'm not 100% sure I can get him. He's always been more than willing in the past to do that. But that's where we are. So it is a tough paper. So as soon as you finish paper 1, you want to start on this paper 2 and just spread it out over time. Hopefully you've been taking really good notes as you go. If you're following my recommendation, the copying and pasting these quotes into the organization of your paper, you might be able to just take that organization and just type around it. Just go in order and just type around and add your own thoughts and comments. Sometimes you'll use the quotes as a quote. Sometimes you'll just restate it in your own words and take the quote out. But if you've been doing that, you are right now probably in really good shape. So we just have a few more things to cover. And remember on the video, I'll get you the video, but one of the students did make his notes of the video, and you have access to that. But I still want you to watch the video. I think you'll find it really interesting. All right, so that's it for the night. Hopefully I haven't worn you out too much on healthcare. I hope you found it just as exciting and interesting as I have.